ये चलता है शुरू नहीं हो। 3 वेळ हे 2 वेळ हे आत्ता नाही खायचे. पाणी यायच्या टायमाला तिसरे दिवशी. सॉरी सॉरी सॉरी. The program live is started.
Yes, ma'am. The live has started. Just give me one more minute.
Okay. हा देऊ ना, कुठला मोठा देऊ? मोठाच आहे ना, 20 दिवसासाठी नाही आहे ना, मोठाच देते ना. तर तू आणून दे तिकडून. नव्वद आहे, 90 आहे, डिस्काउंट करून दे. डिस्काउंट करून सांगा त्याला, मी सांगते अजून 120 रुपये कमी. हा, ठीक आहे. इकडे ऍड करा हा. त्याचे का बनला हा?
Ready,
बरं, चालेल.
ma'am, shall we start?
हा, येस 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 येस, सॉरी हा, दिस आय थॉट आय वॉज म्युटेड. हा हा, आय एम सॉरी.
So,
हा.
a very good evening to all. I am Arpita from the IJCP group. Welcome everyone to the webinar on thin endometrium, how to manage with none other than Dr. Ritu Sanswani, ma'am. Ma'am has done MBBS, MD in Gynae and Obstetrics. She is the founder and CEO of Shyam Well Women Clinic and 360-degree Healthcare Studio, Koregaon Park, Pune. So to give a brief introduction of the topic, managing a thin endometrium, which is the lining of the uterus, is essential for women who are trying to conceive or experiencing menstrual irregularities. A healthy endometrium is crucial for implantation and sustaining a pregnancy. Here are several strategies for managing and potentially improving a thin endometrium. So, to lighten on the topic, I would request Ritu ma'am to please start with it. Over to you, ma'am.
Thank you, Arpita, and thank you, IGCP Group. Thank you, MedTalks, for inviting me here. So, friends, today I'm going to discuss with you regarding how to manage the thin endometrium. What are the tips and tricks? As we all know, the in giving a successful pregnancy, the role of thin endometrium is very, very important. Role of endometrium is very, very important. So, if the endometrium is thin, the pregnancy results are not coming. We are not getting the pregnancy positive results. So I'm starting sharing with my screen sharing. Just now, Arpita has introduced me. Friends, you can connect with me any of the social media, LinkedIn, Facebook, YouTube, or Insta. I'm very passionate about the knowledge sharing. Lot of knowledge sharing, academic content has been posted in my YouTube also, and lot of informative reels also I have posted. Uh, just a second. Just Sorry, friends, because as this is the OPT time. So I always start with my presentation with Mata Durga Stuti. Ya Devi Sarvabhuteshu Chikitsa Rupena Sansita. Namastasyai, 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 Namo. I'm extremely sorry. There is one patient here in the OPD. That's why. So priming of the endometrium and what's the role of the PRP? I'm going to discuss all the things that what are the causes and how can we give the good endometrium to the patients? What are the recent advancements? So friends, I will try to make my presentation simpler. A very famous quote by the Albert Einstein. If you cannot explain it simply, you do not understand it well enough. So there are the hard facts that healthy seed is not enough to get a healthy sapling unless it is grown on fertile soil. Similarly, a healthy embryo needs a receptive endometrium for the success of the for successful implantation. Here we can see a lady is approaching to us with the aim that she will get pregnant. And by the repeated cycles are getting failed due to the thin endometrium. So the prevalence of this is around 2.4%. The endometrial thickness under 7 mm would define as a refractory endometrium with a compromised success rates 8 to 30, sorry, 8 to 13 mm considered as a favorable. Less than 6 and more than 15 mm is considered to be problematic. The bottleneck is the process of implantation. Preparation of the endometrium is directed, and if we get a good endometrium, the chances of the success are good. So here we can see the embryo quality, endometrial receptivity, and transfer efficiency. All three are very important for getting the good, successful pregnancy rates. So endometrial receptivity remains a major stumbling block in any ART success. The endometrium is normally a non-receptive environment for an embryo, except during the window cycle of days 20 to 24. Endometrial receptivity during the implantation window depends on endometrial thickness, endometrial echogenic pattern, and endometrial blood flows. So, receptive endometrium requires the estrogen priming, the time-related progesterone-induced secretory changes in the endometrium, and the other different molecules has been reported. So ideally, the endometrial thickness should be 9 to 14 mm is associated with higher implantation and good pregnancy rates compared to the endometrial thickness of less than 7 mm. The causes which has been reported in the literature, the most common is the Asherman syndrome is due to the tuberculosis of the uterus, prolonged use of CC if it's being used for the for the ovulation induction, postpartum endometritis, septic abortion, pelvic radiation, chemotherapy, hypothalamic hypogonadism, fibroids, Mullerian anomalies, premature ovarian insufficiency, hyperandrogenemia, androgenic, idiopathic. So what are the treatment strategies for this thin endometrium? The hysteroscopic adhesiolysis, the role of estrogens, aspirin, vitamin A, pentoxifylline, L-arginine, and sildenafil. The other components which has been reported, the GCSF, HCG, PRP, stem cells, uterine transplant, and surrogacy. Based on the etiology, number of drugs methods has been used with the aim of improvement of the estrogen level in the endometrium and increases the blood supply to basal endometrium. So now what are the different treatment strategies has been reported by which we are getting the good results. So first and foremost, we have to change the ovulation induction protocol. Instead of CC, we can use this letrozole or tamoxifen or the gonadotropins, which have the advantage of avoiding the peripheral anti-estrogenic effects. The doses which are mentioned to be used are from 6 to 8 mg, uh, 6 to 8 mg up to 16 mg has been reported. Either the oral use or the transvaginal creams are also available. We are using the some gels also. The patches are not very popular in India, being a tropical country, lot of sweating in the patients. So either the tablets or the vaginal gel we are using, or the transdermal gels also. So these are the different preparations. So if we are getting in the fresh cycle, the 380, we have to change the stimulation protocol, addition of the estradiol, adding of the adjuvants, and the freeze all policy. So this I'm skipping these 2, 3 slides. Yeah. So these are the what are the advantages and side effects with the different different estrogen preparations: ethinyl estradiol, conjugated estrogen, estradiol transdermal patch, estradiol transdermal gel. Hmm. So these are the different literature which support the use of the estrogen for this in the fertility sterility journal. Also give the studies in the favor of this presented in June 2019. Then the second reason here comes is the endometritis. The Mycobacterium tuberculosis is considered to be a leading cause of infertility in endemic countries. It causes the implantation failure by immune modulation of the endometrium by causing the hormonal imbalance and releasing the antiphospholipid antibodies. So, correction of the proper endometritis is also very important. For this, the dose of the doxycycline 100 mg BD, usually 14 days we give. The drug which has been reported in the literature is azithromycin 500 mg orally for first day, and then 250 mg for 2 days, 2 to 5 days. Usually, we get good results by the use of this doxycycline. Then the vitamin E also has been reported the doses of 600 mg, 200 mg TDS or 600 OD. Lot of studies have come in the report of this. Then the oral L-arginine supplementation. So a lot of studies have come related to this arginine. It is considered to be a nitric oxide donor. Nitric oxide relaxes the vascular smooth muscle of the endometrium. The doses are 1.5 gram QID, improves the radial artery resistance index in 89% of the patients. 67% of the patients developed endometrium and more than 8 mm. Related to this endometrial health, the role of the probiotics has also been has come. That lot of probiotics gives the good roles in the endometrial health. Especially the studies have shown that Lactobacillus rhamnosus BPL005 was demonstrated to have a protective role on endometrial infections. Lot of studies has been presented in the favor of this. Then we are coming to the other drug, the sildenafil, which we all know, the drug which is considered to improve these factors can improve the ART success rate. Studies have shown this is a phosphodiesterase inhibitor which prevents the breakdown of cyclic GMP and augments the action of nitric oxide on vascular smooth muscle, along with estrogen, leads to proliferation of the endometrial lining, regulates cell growth, angiogenesis, and thus facilitates the implantation. The doses are usually 25 mg QID till the day of trigger, but for the practical purpose I'm sharing, usually the patient is not able to tolerate such a dose of QID, so usually we are giving enough practices up to the TDS and getting the good results. So sildenafil citrate given vaginally or orally, it improves the uterine blood flow. increases the endometrial thickness, give rise to desirable triple line endometrial pattern, improves the endometrial receptivity, improves the implantation and clinical pregnancy rate. So, lot of studies have come related to this. Then the studies have come related to use of this pentoxifylline, though I have not used, but it is reported in the literature. So that's why I'm showing the pentoxifylline, the doses has been recommended the 400 mg per day for 5 days. Only the some studies has been come in the favor of this. Still the product is under studies. Then the role of the aspirin, the dose of the low dose of aspirin has also been reported in the literature. Then the role of the vitamin D, 60,000 international units weekly or 2,000 international units per day has been recommended, has been shown the good results, especially in the patients of the PCOS. Then HCG priming has also been reported. HCG endometrial priming for 7 days in the proliferative phase with estrogen in frozen cycle seems to be highly promising. Studies have shown that HCG priming of the endometrium leads to significant improvement in thickness and pregnancy outcome. Hmm. 150 international unit HCG from day 8 till day 14 or 15, along with the estrogens in FET and donor egg cycles. Additional effect of adding the human HCG to the frozen cycles, lot of studies have come in the favor of this. So, yeah. Then coming to the other molecule, the GCSF, which we were using some years prior extensively, still it is being used, the role of the granulocyte stimulating factor. The first was introduced by the nomenclature for the improving this endometrial thickness. So it can be given the subcutaneously or intrauterine. What we are using is the intrauterine. The dose is available in the pre-filled syringe of the 300 microgram. We are using 2 to 7 days before the embryo transfer and using in the IUI cycles also. So what we need is IUI catheter, insulin syringe, lithotomy position, and partially full bladder. Mhm. So the difference has been mentioned is the 300 microgram per is approximately 6 to 12 hours before the HCG administration. Repeated GCSF infusion if the endometrium is less than 7 mm on the day of the pickup. Usually the results come good with the one dose also. Then, usually, as I told, that this can be given intrauterine or subcutaneously. With the subcutaneously, the leukocytosis is a major problem. So, and some patients may get the fever also. So, we are using as the intrauterine. Then, coming to the PRP therapy, a modern medicine boom for repair, restoration, and rejuvenation. Hmm. Autologous platelet-rich plasma is collected from the peripheral vein through thoroughly activating the platelets by clotting, releases the cytokines and growth factors, EGF, transforming growth factor, platelet-derived growth factor, and epidermal growth factor. So we know these platelets are containing the dense granules and alpha granules. These alpha granules contain the mediators such as factors 5, 8, fibrinogen, fibronectin, and platelet-derived growth factors, and the delta granules. Hmm. Hmm. So these all will help uh, in the tissue regeneration. Hmm. So this is showing the tissue regeneration, angiogenesis, epithelialization, proliferation and differentiation of the cells, and synthesis of the collagens. These are the different factors which have been reported. So, making of this platelet-rich plasma, mm, there are the different methods has been reported that how we can make this PRP. So, but making of this PRP is very easy. Anyone can do in the OPD. Mm, mm. It doesn't require the anything major. Everyone can do. Whoso is having the centrifuge machine. I have posted a lot of videos related to this. Today, our topic of discussion is the thin endometrium, even though I will try to show something related to this. So, in this, we advise the patients for the because as this PRP is made from the patient's own blood, so that there are no chances of any reaction or any problem. Hmm. The intrauterine infusion of PRP is used in endometrium with the view of the growth factors and provided by the platelets will help in restoring the deficient endometrial function. So usually we prepare with the 15 ml of the blood using the double centrifugation, and final preparation of 0.5 ml is infused on 10th and 13th day of the cycle. So there are a lot of studies has been come related in the favor of this, either the hysteroscopic installation or by the intrauterine. I'm usually doing the intrauterine. These studies has been presented in NIH at 2020 only. So studies has come from Leela Nazri also in 2016 related to the favor of this. Hmm. So this making, as I told, that we have to use the double centrifugation. This is the one method what I am sharing here. What I am using in so what we use is the 13.5 ml. Hmm, hmm. 13.5 ml of the we take the 13.5 ml of the blood and 1.5 ml of the anticoagulant ratio. What we are using is the 1 ml anticoagulant and 9 ml of the blood should be maintained. Depending on the need of the additional number of the tubes can be set up. Discard the remaining anticoagulant. Sorry. So let the we usually advise a double centrifugation. First centrifugation is for the 15 minutes at 1500 RPM. Then we take the upper plasma and then again put it for the double centrifugation. Then second time what I am doing is 3500 RPM for 15 minutes. And usually within half an hour we are getting the good PRP, the platelet-rich plasma. So this is the method by which what I am using. Lot of studies have come. This is the recent study which has been published in 2022 related to the use of this. Then the studies have come related to the stem cells, that mobilizing the endometrial stem cells uh, for the preparation of the endometrium, the different cells, the epithelial progenitor cells. Lot of studies have come the cell-based therapy in the thin endometrium and Asherman syndrome. Hmm. The neuromuscular electrical stimulation and biofeedback therapy is the another very experiment on the improvement of the poor endometrial growth. Stem cells are considered to be as new agent for the treatment of female infertility. Mhm. So this is the something more detail about the use of the stem cells. So endometrial reconstruction with this the with for the Asherman syndrome and the patients where it has been not useful. Yes, of course, we are advising for the stem cells. Mm. Then in ultimately where the nothing is working out, of course, the surrogacy and uterine transplant are the last options. Yes, the surrogacy, there are a lot of legal issues are going on at present. Still, there is some in the guidelines, still not everything is very clear. The uterine transplant, of course. Um, so the endometrial thickness and pregnancy rate, the studies have shown the pregnancy rate was higher, 12% versus 8% in the trilaminar versus non-trilaminar group, and even higher at 39% when the endometrium is both more than 6 mm and trilaminar. So we have to select the best seed, prepare the best soil. We have to plant at the appropriate time. Taking a different approach achieves a pregnancy in many cases that have failed repeatedly. So soil thickness of 7 mm is must for achieving the pregnancy. GCSF, endometrial scratch, and stem cell therapy is a promising future. Video is not getting. So thank you, friends. This is the something what I want to share related to the management of the thin endometrium. Uh, Thank you for your interest and time. If any questions, I can answer quickly, one or two, or otherwise you
Sure,
can
ma'am.
post in. Yeah. Otherwise, you can write in the post in the YouTube. The program has gone live. I will definitely answer there because at now the some patient is waiting for me in the OPD. So yes, if there are any questions quickly, I can answer one or two. Yeah.
Yes, ma'am. I will ask only one or two questions.
Yeah.
So
Yeah.
first question is, what are the common pitfalls in managing thin endometrium
That
and how
already
they
I
can
have
be
shown.
avoided?
That already I have shown
Right,
in the slide. Huh? Huh. Already I have shown
right,
the
ma'am.
first.
And another question is, how do you approach patient counseling and education regarding thin endometriosis?
Endometriosis or endometrium? My topic is endometrium, not endometriosis. Endometriosis is different thing. Endometrium is different thing.
Okay, ma'am. And
My topic is
the
thin
last one,
endometrium. Thin endometrium already I have shown. Na? Yes, of course you have to counsel the patient. You have to tell them about what are the recent advances, what we can use. Of course, with the PRP, we get a lot of patients who are not responding to GCSF and HCG. They will get the good results with this.
right,
Yeah.
ma'am. The last question is, when is surgical intervention indicated for thin endometrium?
Surgical intervention we are doing in the cases of the Asherman syndrome, if the patient is having a uh, if patient is having a very thin endometrium and if we are putting all the things and results are not coming, of course if that is due to Asherman syndrome, of course the hysteroscopy we do, and in some patients we put the device for some time, and in some patients of course we are giving this PRP. With the PRP we are getting a very good results. So related to the first question, I think that doctor has joined late, so they can go through the presentation, or already I have shown the slides in the earlier. Otherwise, rest, what are the questions they can put in the YouTube chat? I will definitely try to answer.
Okay, ma'am. Won't take much of your time now.
Okay,
Thank you, ma'am. Thank you so much for your
yeah,
valuable
yeah.
time.
Okay, okay, dear. Bye, bye, bye. Sorry, huh? Sorry for
Take
that.
care.
Lot of
No,
disturbance today, huh? But, yeah, bye.
no problem, ma'am. Take care. Take care.
Okay, dear. Bye. Thank you.